Okay, so maybe I'm gonna get us started. I know we're expecting a lot more people, but I'm gonna just do, I guess, some housekeeping introductions, speak a little bit about the plan for today, so that will give time for people to join us. So welcome everyone to this webinar today on standard and regulation under the Health Profession and Occupation Act. My name is Joanie Bouchard. I am the interim Chief Regulatory Officer for the college. I have today with me Susan Paul, who will speak to two aspects during the webinar. She will speak to the physiotherapy profession. Susan is the Regulatory Transformation Advisor for quality practice at the college. We also have Alison Clark, who is the Occupational Therapy Practice Advisor, and also Elaine Van Oosten, who is one of the two Dietetic Practice Advisor at the college. I wanted to start this meeting by acknowledging that the Office of the College of Health and Care Professional of BC are located on the ancestral and unceded territories of the Coast Salish people, specifically the Musqueam, Squamish, and Tsleil-Waututh Nation for the Vancouver office, but also the Lekwungen people for the Victoria office. We're very conscious of the privilege we hold that allows us to carry our important work on these territories where the First Nation people have maintained a special relationship with the lands and waters for thousands of years, and where this relationship continues today. So, the content for today, just done a little bit of welcome. We'll speak about the purpose of the webinar. We'll get updates for three professions in terms of standards and regulation. And then we have planned for lots of time to take questions from the floor. You'll be able to use the Q&A section for that on the webinar. We have also received pre-submitted questions. A lot of them were used to build the content for this webinar, so you should see some answer to your question along the way. It is today the first webinar of a four-part series. We have grouped some profession together for these webinars based on the degree of changes that have happened with the transition to the legacy set of standards that you had and the regulation based to our new framework. People from all professions were welcome to attend any of the webinar that we are hosting. So we're definitely not excluding from any profession that we regulate to participate in these webinars. And we're also hoping, seeing the interest that we're having, that we're going to be hosting more of these engagement sessions with all of you. I'm going to move forward to the next slide, please. As I've said, we have received some pre-submitted questions to the webinar today. A lot of them spoke to some content that we were able to address between December and March prior to the transition to the HPOA. There's been a lot of changes that has happened over the last few months at the college. So we fully understand that some of these webinars, maybe you were not able to attend them, you may have missed them, but they do contain a lot of information that we have received in some of the questions. So we wanted to make sure that we would point out to these as a resources for you. You can find them on our website. They're available under the HPOA section, and they cover a wide range of topics, but specifically with what's relevant for today, the webinar on delegation, the webinar on ethics and practice standards, and the last one that we did on restricted activity and certified practice would be relevant to you. Next slide, please. So why we're offering this session today, the college wants to be able to kind of take a step further and be able to help you in understanding and applying the new ethics and practice standard. As I said, we know that there's been a lot of changes since amalgamation, since the transition to the new act, And this session is meant to cover some of the main themes that we have received in terms of question and helping you in continuing to transition under this new legislation. Next slide, please. So what to expect today? As I said, we're going to highlight some comments question. We're going to clarify expectation related to new standard and the regulatory framework. We want to support the consistent understanding amongst profession and also provide an opportunity for question at the end. So we've kind of built this that we would have probably at least like a 20 minutes, hopefully, of question available to you. We'll also try to answer a question as we can during that we are presenting today. So I think with that, yes, this is the last slide before I turn this on to Susan. Just a reminder in terms of where you can find relevant resources on the topic we're presenting today. You have on our website, you'll find under bylaw and legislation a link directly to the college ethics and practice standards. And today we are also speaking about two regulations that are relevant to ethics and practice standard, which is the health and care professional regulation. So that is our college specific regulation, and also the regulated health practitioner regulation that has the new centralized list of restricted activity under the HPOA. Okay, so next slide.
Advance. I'm just having a technical issue. Thanks.
Of course. Oop, I went too fast. Don't want, Susan, I will hand it off to you as here we go. So Susan Paul will be doing the first portion, which will be for physical therapy.
Right, and I just want to acknowledge the slides are quite small at the moment, and I think our comms team in the background is doing their best to try to get those in full screen. So thank you for your patience with that. Thanks, Joanie. And yeah, just wanted to acknowledge that I'm presenting today on behalf of Sue Murphy, who unexpectedly couldn't be here at the last minute. So Sue's prepared the content on the slides, and what I found interesting is when she thought about, or when she looked into the data about where we're getting questions about the regulation and standards for physical therapists, unlike some of the other professions, the questions are really centered around restricted activities and certified practice. And that's not entirely surprising because for physical therapists and occupational therapists, unlike dietitians, restricted activities are new. We've not had those enshrined in our regulation previously. So the whole notion of restricted activities and then the new concept of certified practice, this is a new concept for physical therapists and occupational therapists. So it's really not that surprising that this is where the questions land. So Sue's put together some slides that highlight where the common questions are coming from. So firstly, by and large, they're coming around the requirement for certified practice with pelvic health. And so if you look right to the regulation, that specific restricted activity is defined as a certified physical therapist may insert an instrument, device, hand, or finger beyond the labia majora or anal verge for the purpose of assessing or treating the pelvic floor. And so what I want to draw your attention to is that the restricted activity there is not broadly for pelvic health, but rather it's that narrow activity, restricted activity of the insertion. So that's where we are getting a lot of questions. And so it's really, as I say, it's focused on that piece of the restricted activity as opposed to being a certification broadly for pelvic health. Next slide, please. So what does this mean in practice? Again, just to reiterate, if you include internal examination or treatment in your pelvic health services, you must complete the certification process. So, and once you have received your certification from the college, you will then be able to state that you are a PT who's certified to provide internal exams, or, I mean, you may be conveying that to the public as pelvic health, but you can say that you are certified at that point. If you don't include internal examination or treatment in part of your pelvic health services, you do not need to be certified. So we're hearing from lots of physical therapists, and we know this to be the case, that you may be treating somebody postpartum for something else, and you may be having conversations, you may be providing education, you may be doing, sort of a more basic assessment to provide some education to your clients, but you are not doing internal exams. So in that case, you do not need to be certified to continue to have conversations around pelvic health with your patients. But you, of course, would not be able to state in that case that you're certified. So that requirement for certified practice is really around the performance of an internal assessment and examination and treatment. Next slide, please. Okay, so this is interesting. This is around what we've discovered is the overlay between the two restricted activities, spinal manipulation and reduction of joint dislocation. And we've very kindly had conversations with some physio experts in this area who highlight the fact that if you are doing a spinal manipulation, there are some, depending on what you read, there's some overlay between whether what exactly is happening, say, at a facet joint, and whether that might actually be a reduction of a joint dislocation. So what we want to clarify today is that from a ministry perspective, those are two separate activities. So spinal manipulation is covered by the spinal manipulation restricted activity language. So physical therapists have been granted the restricted activity of moving a joint of the spine beyond the limits of the body can voluntarily achieve, but within the anatomical range of motion using a high velocity, low amplitude thrust. So that's what covers your authorization as a physical therapist if you have the competencies to perform spinal manipulation, that's the restricted activity that applies if you are doing spinal manipulation. It is a restricted activity that the ministry does not require certification for in the regulation. Next slide. What we're talking about with what the ministry is talking about with spinal manipulation is reduction of a dislocated joint, and that requires certification according to the regulation. And the intent there is around, reduction of joint dislocation. So, for example, patellar dislocation, shoulder dislocation, so immediate treatment of sports injuries that's often happening, on the field of play, those kinds of things. So just to kind of clarify that spinal manipulation authorization is under a restricted activity that does not require certification, still requires competence, and that the reduction of joint dislocation does require certification, certified practice. Next slide. Yeah, and that's just a reminder again, the sort of that caveat that even though certification may not be required for certain aspects of your practice, whether it's a restricted activity or not, all licensees have a regulatory obligation to be competent in the services they provide. So just because physical therapists have the restricted activity of spinal manipulation, I shouldn't be going in including that in my practice because I don't have the competencies myself to be performing spinal manipulation. So that authorization to do spinal manipulation by physical therapists does not change that. And so again, that's covered by sort of our code of ethics, but also in the restricted activities and certification standards that talks about our requirement to practice within the bounds of our scope of practice, but also within the bounds of our own competence. So you can, if you want more detail on that, you can have a look at the language in the restricted activities certification standard or the code of ethics or the evidence-informed practice and outcome evaluation standard. I think that might be Sue's last slide. So I'm going to turn it over to my colleague Allison, the OT practice advisor.
Hi, everyone. So my name is Allison Clark, and I'm the OT practice advisor, of course, as Susan mentioned. And similar to physio, I would say a lot of the new or hot topic questions I've been getting at practice support have also been related to the restricted activities and the certified practices. And as Susan noted, those are new for OT. So previous to this HPOA, we have never had any restricted activities included in the regulation. So as noted, effective April 1st, when the HPOA came into force, OTs now have 3 restricted activities in our regulation. So those include administer oxygen by inhalation, airway sectioning, and wound care below the dermis. And so the important note there is that with airway sectioning and wound care below the dermis, those both are certified practices. So they require certification, recognizing that those were added relatively late into late March, so close to the start of April 1st. And so the college were still in a transitional process establishing the certification process. But there are more details, of course, on our website or they've been sent via email. And we also do have a past webinar more specific to that as well. Next slide, please. So one of the most frequent questions I've been getting is related to the new wound care restricted activity. So how it's defined in the Health and Care Professionals regulation is occupational therapists may perform a procedure on tissue below the dermis for the purpose of wound care. And so, of course, I've been receiving quite a few questions asking whether certain activities or tasks, qualify or are considered below the dermis. And ultimately, below the dermis is an anatomical reference point. So it's not necessarily a list of specific techniques or interventions. Next slide. So ultimately, what does that mean in practice, right, for you as OTs and licensees? So really the determination of whether a specific activity or a task or intervention acts on tissue below the dermis is a clinical judgment. So that falls to the licensee, to you as the OT. So, of course, there's many wound care activities that do not involve tissue below the dermis, so those wouldn't require certification. But similar to what Susan mentioned with pelvic health, we're still looking at competency is still always required. So even though certification might not be required for some of the aspects of OT practice, there's still the obligation for OTs to be competent in those services, and there's more details that touch on that in the restricted activities and certification standard, as well as in the evidence-informed practice and outcome evaluation standard. And then we also do have an OT-specific competencies document that's from ACOTRO, so the Association for Canadian Occupational Therapy Regulatory Organizations. And so that talks more about those core competencies as an OT. Next slide, please. And the other area that I've been receiving quite a few questions on is the changes in the supervision standard. So specific for OTs, quite a few questions looking at the supervision of occupational therapist assistants. So in the new harmonized ethics and practice standards, we have a harmonized supervision practice standard, and so that applies to all licensees and all professions. Whereas, of course, for OTs in the previous practice standards, we did have a specific practice standard that looked at the supervision of occupational therapist assistants. And so, of course, not all professions regulated by the college utilize assistants in the same ways. So in the context of OTAs and when assigning tasks to an OTA, the term here is, as I mentioned, assignment, so not delegation. So OTs do not have the ability to delegate an aspect of practice or any restricted activities to occupational therapy assistant. And so ultimately this standard's not intended to change practice. So it's not intended to change practice from what OTs were doing under the OTA practice standard versus this new supervision standard. So it's still looking at assigning activities appropriately, ensuring that the supervisee has the competence, that it's safe, appropriate to assign that activity, to still be supervising appropriately, proportion to the risk associated with that activity. And the OT is you're still retaining accountability for the overall care of the patient and, of course, documenting accordingly. Next slide, please. So for OTs, if you're looking for a bit more detail, further clarification, understanding of how that applies in the context of assigning tasks to an occupational therapist assistant, the ACOTRO position statement is still a really relevant resource. So that can be found on our website. Again, that comes from ACOTRO, the Association for Canadian Occupational Therapy Regulatory Organizations, quite a mouthful. And it's the position statement regarding utilizing occupational therapist assistants in occupational therapy service delivery. So that looks more specific at the role of the OT, the OTA. It talks about the terminology distinctions, assignment, delegation, consultation. Of course, I know consultation comes up as a question quite a bit also, and there are distinctions, of course, in there. And it covers the accountability, the different supervision approaches, how does consent work, record keeping. And so again, it's that similar statement that the OT still remains fully accountable for all the OT service components assigned to the OTA and should only assign activities that the OTA is competent to perform. So I hope that that helps clarify, because I know that that has definitely been a question that's come up, and we have covered this also in some of the previous webinars, so there's additional details there as well. That's everything for me from an OT perspective, and so now I will hand over to Elaine with dietetics.
Hi, everybody. My name's Elaine. I'm a practice advisor, one of two here at the college, and I thought I would start off by providing this little table that outlines the changes from our legacy standards to the harmonized standards. There are 5 of them listed here. The first is record retention. And so you'll see in the legacy standards that we had a range of record retention requirements for timeline, and that's all been harmonized to 16 years now. So that will impact those people working in private practice and also working in long-term care. So the standard has been changed to 16 years. We used to have a policy for co-signing student records. This was required as part of our CDBC legacy standards. This is now not required with the harmonized standards, but it is important to point out that workplaces will set out different requirements. So check with your policies and procedures and your decision support tools within your workplace to determine what is required of you when you are supervising a student. In terms of facilitating access to health records, this is primarily for private practice. Our language in our legacy standard used to say that it needed to be accessed by a member of the public, patient to client, in a timely manner. This is now changed to within 30 business days. Similarly, when records are relocated, we were silent in our standards about the requirement for communicating that to the college, and now the CHCPBC requires that location, a notification of a location change within 30 business days. And the big heavy hitter that we've had a few questions about is regarding social media and how this changes social media posting allowability. I wanted to point out here that we used to have, since 2021, a ban in testimonial posting. Where the college is looking at this differently now, and so our language is that those people posting to social media, those licensees who are going to be using social media, if testimonials are used, they must adhere to the marketing, advertising, and promotion standard. Furthermore, I had a few questions of generally more about social media, and I just wanted to point out that if you go and have a look at the marketing, advertising, and promotions practice standard, it does set out language like ensuring that your posts are factual and accurate, verifiable, respectful, and culturally safe, avoiding false, incomplete, misleading, deceptive claims. Certainly no discriminatory wording is allowed, no defamatory wording. That is not different than our legacy standard was. But this applies also to social media, which falls under marketing, advertising, and promotion. Similarly, with social media or any sort of a private practice, licensees are only allowed to speak to products and services that are within dietetic scope. And you also, similarly, not advertising unreasonable expectations or guarantees about results. That's very similar to legacy standards. And in terms of being very transparent with partnerships, that's also not changed, using appropriate hashtags and being very upfront and transparent with any partnerships that you're undertaking as a licensee in a private practice setting. Next slide, please. The absolute most common question that we've gotten in dietetics doesn't have much to do with restricted activities, because those are not new to our profession. Rather, we've gotten just dozens of questions about use of title and what is protected title and what title dietitians may use. So dietitians historically have been called registered dietitians, or RD for short. It is important to know that dietitian has only ever been the only protected title under the HPA, and also continues that way under the HPOA. where the term registered or RD was protected was more under our legacy bylaws. And we've put out as CHCPBC a statement that says that the college doesn't currently have a list of approved abbreviations. So RD is technically not a protected title or an approved abbreviation. The use of registered and licensed is not required. But having said that, the college is not going to treat the use of the term registered or licensed or RD as a breach of standard. So I leave it with each of you as licensees to make your own clinical decision about how to do that. And I would like to move to the next slide, please. So the restricted activities, as I mentioned, is not new to our profession. Everyone in the profession knows the restricted activities as A, B, and C. These have now been translated into 50 through 53. And in this table, we've set out how it translates. So for restricted activity 50 for design therapeutic diet, that pertains to former restricted activity A for enteral nutrition and B for parenteral nutrition. It's important to note here that a new restricted activity that falls under this is the design of oral diets, oral therapeutic diets. So that was already within scope for us. So that continues to be in scope for us as well. Restricted activity 51 is compounding a therapeutic diet for EN and PN. That's the wording in the restricted activity. And this doesn't change for us because we are limited here that we are allowed to compound for enteral nutrition only in this formerly restricted activity A. For dispensing diet, a therapeutic diet, this is limited to oral and enteral only. So again, that is no change for the enteral nutrition piece of it, continues to be restricted or continued from formerly restricted activity A. And for 53, administering a therapeutic diet, the language includes EN and PN in that restricted activity, but dietitians in BC are limited to administering for enteral nutrition only. That includes the teaching and administration part of enteral nutrition, which we all recall as being restricted activity C. It's important to note that these are entry level skills. Next slide, please. So this is where things change a little bit for dietitians because we also have in our regulation restricted activities 19, 20, and 24. 19 is inserting an instrument, device, hand, or finger beyond the point in the nasal passages where they normally narrow. This is limited by limited for the purpose of an EN administration only. So this might be for insertion or removal of a nasoenteric feeding tube like an NG or an ND. Number 20 is the same language, but for beyond the pharynx. Again, it's only for the purposes of doing or enteral nutrition provision. So it wouldn't apply for something like an NG tube that's inserted for decompression, for example, but there's no intention to use it for enteral nutrition. So this one would translate to insertion or removal of an oral tube, an oral feeding tube, NG or otherwise. The last one is insertion of an instrument, device, hand, or finger into an artificial opening of the body. And this is a certified practice that would encompass replacement or removal of a balloon retained enterostomy tube, including checking, removing, and replacing the volume in a balloon retained tube, checking the retention device. We don't currently have our program of study yet for this, but it will require licensees who wish to become certified to undertake a program study, which will be developed and is currently being worked on in consultation with health authorities, subject matter experts, and other interested parties, such that licensees can meet the competencies and continue to demonstrate currency in those competencies, because these 19, 20, and 24 are above entry level. So we wouldn't expect our entry level dietitians to be able to undertake these tasks. All licensees must be certified for this purpose. And that is the end of my slides. I will pass it back to Joanie.
Thank you. I was trying to answer a question. I'll finish that in the chat after. Thank you, everyone, for providing update. And I see that As people are listening from one profession to the other, it prompts to think about question about, hey, how does that apply to me? Or do we have to do that? So I think it's a great benefit of being able to hear from different practice advisor today. Before we move on to our question section, we wanted to take the opportunity today to highlight another very specific and unique engagement opportunity that we have this week, which is a webinar on Wednesday, June 10, also during lunchtime, that is offered for free to all licensee of the college. That is, the title is Cultivating Safe Spaces, Self-Care, Belonging, and Human Capacity, which will be offered by Elaine Alec. She is an amazing speaker, and the college has been working and preparing this webinar since last year. So we're really hoping that licensee will take the opportunity to hear and learn from Elaine. So we wanted to make sure that if you had not seen this yet through our newsletter and communication, that you would consider attending this week. So moving on to the question portion of the webinar, we will have someone to moderate the question. Susan and I will probably take a first stab at answering the question and inviting the practice advisor to add anything more specific, because there's at least one question that I saw in the question box that was very OT specific, so I may prompt Allison to contribute to that one. But is it I'm not sure if it's Anita or Michelle who will moderate the question.
It's me, Anita.
Okay, great. So I'll let you start.
Thank you, Joanie. So I'm going to pull from some of the themes that were submitted in advance when we invited the participants to tell us what they were most interested in learning about. So lots of overall interest in just the general changes and how to apply to practice and what's new, what they need to know. And then a number of people focused on ethics and said they were interested in learning about the changes to the ethics standards in particular. And somebody noted ethics is coming up quite a bit in practice. So perhaps Joanie or Susan could respond to this. What should licensees know about the ethics standards as in terms of their application to clinical practice? And who can they reach out to with ethics-related questions when they arise in practice?
Sure. So that's a good question. And I think, you've heard it before, but it's worth repeating that the new standards are a harmonization of what we saw in the legacy, 7 sets of legacy standards. And the way they're written might appear that the way they're written may be different than your legacy standards, but the expectations largely remain the same. And so I would say the same around the code of ethics, that you would still be welcome to use. I know Accutro has a nice companion document on code of ethics. If you're looking for some more specific detail on code of ethics, that document is a good option. If you found your legacy code, helpful, that's something you can still refer to, but keeping in mind that the standards that we're held to as licensees as of April 1 are the new ethics and practice standards. And if you have questions, Allison is your person. If you're an OT, reach out to her. She spends her literally all day answering practice and ethics questions from OTs in practice. And so she's probably your best and first resource. If you do have a scenario you want to discuss with her, Allison will can either answer via email or arrange a Zoom call, a Teams call. But I would say Allison is your best scenario if you want something more specific OT related around ethics.
Thanks, Susan. I'll do another one from the earlier questions, and then we can pull from the live ones. A couple of folks wanted to ask about how to improve their understanding of the standards and the rationale. Can you provide a bit of context of kind of this whole shift and why these changes were required as part of the move to the Health Professions and Occupations Act?
Sure. I mean, my first plug is going to be for the March 18th webinar, where we dedicate the whole sort of hour of the webinar to that very question. But sort of briefly, I can say it was motivated for a couple of reasons. One, the HPOA in section 70 and 72 actually requires colleges to have standards that address some specific topics. And not all of the legacy standards had standards addressing those things. So for example, around addressing treating treating family members, or sort of prohibitions on sexual misconduct. Some legacy standards didn't actually have that articulated in standards. So in order to be compliant with the HPOA, we needed to change standards to ensure all of those pieces were included. And then second, we had some things that were in conflict that didn't really make sense for one organization to have differences from one profession to another. So the most obvious one is around record keeping timelines, and that varied across the 9 professions, how long licensees were holding records. And so we got a legal opinion on that. And ultimately, it is largely because of what is written in the Limitations Act. The legal advice was to go with the 16-year requirement. So now all licensees are required to hold records for that long. So I would say the main purpose was to correct where there were discrepancies between standards and to make sure that the standards were compliant with HPOA requirements. And it now means that we have one set of standards to refer to for some of the professions. Like, I think partly why we don't have as many questions around the standards from OTs and PTs, for example, is that the legacy standards were less prescriptive. So they looked a little bit more like the current set of standards, whereas some of the other professions, and I would say particularly optometry and psychology, their standards were quite a bit more prescriptive. So they have more questions around the standards than the regs or restricted activities because it represents a bigger shift. So for some of the professions, the standards don't look very different. But what I want to reassure you is that this project around the harmonized standards really was that it was harmonizing what the legacy standards required. And so they should look very similar to requirements from your legacy standards. They may just be written with different language or at a slightly sort of less prescriptive layer or level.
Thanks, Susan. One of the live questions is, how does the college plan to uphold standards related to licensees practicing within their profession-specific scope beyond the areas of restricted activities and certified practice? Specifically, how would the college approach situations where a licensee frames a service as supporting something within their scope, but the primary assessment or intervention method appears to fall outside that profession-specific scope? For example, a physical therapist providing mental health treatment, or primarily cognitive rehabilitation after brain injury, rather than intervention through physical or mechanical means.
Yeah, I don't know, Joanie, if you want to start. I mean, I guess what I would say is that we'll continue to reinforce the same way the college has always reinforced around scope. So I don't think that the new standards or regulations change that. So that would be, we would enforce scope or something outside of scope the same way we always would, in recognition that the ministry has written the regulations in acknowledgement that there is a lot of shared scope. So there will be areas of overlap, and that's a good example between PT and OT, but fundamentally at the end of the day, the physical therapist is providing physical therapy services and the occupational therapist is providing occupational therapy services. Both of those two professions have to be providing services that are within scope. I don't think that anything in the regulation, the new standards or regs, changes the way the college would follow that up. Joanie, have you got anything more to add to that?
Well, on a higher level, I think what I would say is that even though there's been lots of changes with this new legislation, the college still has the same mechanism and tools to enforce and oversee practice. So one tool are the ethics and practice standards and setting expectations of how people practice. In regulation, you have a scope of practice that is a very broad definition of what the profession does. It's not meant to be exhaustive or necessarily restrictive, but it connects to the standard of practice where there's an expectation that if you perform services, you must be competent to do so. It must connect somehow to your scope of practice. The other tool that we dispose is that, of course, if we have reasonable ground to believe that someone is not meeting those expectation of practice and is in breach of either the standard and the regulation, then we always have the complaint pathway to looking into concern. That hasn't changed whether we were under the prior act or this new act. So, yeah.
Thank you. Here's another question. Back to certification. Some restricted activities require certification by the college, some do not. It's the questions are bopping around while people are entering them. I use spinal manipulation as the example where it doesn't require certification, but joint dislocation reduction does. Yeah. Where a restricted activity does not require certification, how does a professional verify they are qualified to do the restricted activity? Is there a list of, quote, qualifications, i.e., you have to have taken this or that course to be qualified? Or is the onus on the service provider?
Yeah, I can speak generally, and then Susan, you can add maybe something that's more specific to physiotherapy. But when we did the webinar in March, we spoke to, of course, how restricted activity have been kind of designed and included in the regulation. So Ministry defines a list of activities that are now restricted in the regulation. It typically means that it has been considered to be higher risk or invasive or requiring specific knowledge. And then in our college-specific regulation, you'll see 3 levels that can exist for restricted activity. You can have a restricted activity that's been granted to your profession as full, meaning that you can perform it to its full extent as to how you might read it in the regulation. It can be limited because there's a specific purpose for which you can perform it. An example is performing procedure below the dermis for the purpose of wound care. So in the case of OT, that activity has been granted as a restricted activity that's limited because we have attached a purpose to it. You cannot perform a procedure below the dermis if it's not for the purpose of wound care. The 3rd level is certification. So you can only perform the restricted activity if you are certified by the college. That is a policy approach that ministry is using if they generally determines that's not entry level for a profession. So if it's not something that you have acquired at entry level, either meaning through your general education or and that would have been tested on your national exam, then ministry is expecting the college to certify this. So if your restricted activity does not require certification, it means that it has been deemed to be generally entry to practice, which is something you should have acquired through your education. It does not mean that you would feel competent to do it on day one. Maybe you would want to have more experience, mentorship. Maybe it's not something you have really seen during your practical training, but it is something that the college does not add another regulatory intervention on top of it. Mm-hmm. Suzanne, do you want to add more specific to compare those two maybe, or anything else you want to add?
Yeah, well, just, with that question specific to spinal manipulation, the second example that they provided is correct, which is, yes, it's the physical therapist that determines, or for any restricted activity where you're going to be performing it and you need to ensure you're competent. Some of it will be you may have acquired quite a lot, like, so for the physiotherapy example, suctioning, we get quite a bit of education during school, and you graduate, you may feel you're ready to go with suctioning. Spinal manipulation, there's a lot more variation. It also depends when you graduated, how confident you would feel when you left school about whether you were competent to perform spinal manipulation. And, most people would say they take additional postgraduate training before they do spinal manipulation. But there are some entry-level programs, as I say, depending on when you graduated and what the content was, where you may feel comfortable doing, a thoracic manipulation, or you may be competent in a limited number of spinal manipulations, but if you were going to do more, you would take more. And then in that case, if it's a restricted activity not requiring certification like spinal manipulation, then it's up to the health professional to determine the courses that they're going to take to become competent in that area. I think that answers the...
Thank you. Here's a new question. In our practice, we've had much discussion about the language shift from client to patient. What is the college's stance on licensees shifting to the patient terminology.
Yeah.
We have some who are happy to shift and some who are not, given that patient can have a power imbalance. Any guidance would be helpful.
Yes, thank you. I'm so glad somebody asked that question. That's also covered in our March 18th webinar on the standards, but I'm happy to repeat it here because I think there's two things. One is the reason we shifted, and two is whether or not you need to use that in practice. So I think those are two different things to consider. So the reason we shifted to patient is that partly that was legal advice because that's what the HPOA that language is patient. And so the recommendation was to stay to remain consistent with the language of the HPOA. So that's the short reason for why the standards use the term patient. The second piece is about what term you choose to use in practice, and you can continue to use client, patient. Some of our psychology colleagues would even choose, wouldn't necessarily like to use client or patient. So I think there's a difference between what's appropriate for you to use in your own practice setting, and it may not be patient, and that's okay. But just to know that the standards are written using the term patient, and in fact, in the glossary at the end of the standards, it sort of defines that patient is a broader term and who it includes.
Thank you. We have a number of questions with respect to the pelvic floor physiotherapy. Are there any changes with respect to that? Now, those did come in prior to today's presentation, but a couple of others I think have come in the Q&A today. So is there any more that you wanted to clarify with respect to that process? Who is eligible to apply to provide that service? And I think there was a question about whether OTs would be able to become qualified for that, which I'm scanning for right now.
I answered that one
in
the chat, so that's probably why. And it's just an opportunity maybe for me to repeat that too. So in our college-specific regulation, whose name Health and Profession, I'm forgetting the name now. I'm going to look at it because I have it open. Health and Care Professional Regulation. Thank you. You will find a section for each of the designated profession that we regulate. So that's how the regulation is structured. So prior to April 1st, you would have found all of these in different documents. There was a dietitian regulation, there was a speech and hearing regulation. Now all of these are into one, but you will find information for each of the designated health profession we regulate. And under each, you will find the scope of practice, and the restricted activity that have been granted to that designated health profession. So restricted activities are granted, like you have a long list of centralized, and then ministry decides if number 8 is granted to this profession, and then they will say, is it a full, limited, or certified restricted activity? So when it comes to OT, currently, the restricted activity that have been granted to that profession, Allison went over them. In her section of the presentation, there are 3 of them. So inserting fingers, I quoted fingers, device, instrument, and I feel like I'm missing one. I think there's 4 beyond the anal verge or the labia majora has not been granted to OT. So that means they could not perform internal assessment. Back to pelvic, what I will say, Susan, and I will let you take the rest. As we said on April 1st, the college focused to establish a transition period for people who were already performing these activities in practice because physiotherapy had not been brought under the restricted activity model in British Columbia. People who wish to practice this in the future but do not qualify for the transition period because they were not practicing this, they did not have additional education in order to practice this competently, will have to go through the regular pathway that will be available after June 30th. We are still working on developing what those requirements will be. There are categories that the board must approve as part of a certification program. It includes relevant experience, supervision, and then education and training. There might also be some prerequisite that exists, for example, in certification for speech and hearing. Typically, we consider that the prerequisite is for you to be a full licensee and that you have completed all of the education that allows you to be a full licensee, but those will be generally the three categories that you will see as part of a certification program. So relevant experience, for example, if we require numbers of years, that's the case for dry needling, for example, and then supervision, and then education and training that would be required for you to become certified. So I think that's what I could speak generally to certification. And then Susan, if you want to add anything else to help maybe provide more.
Yeah, I think we've probably covered it now, Joanie, but what I would say is if there are specific questions that you feel we haven't answered with enough specificity, or you have additional questions, Jeanette and Sue, our two practice advisors, are happy to take questions after the webinar, and I'm sure we have a slide at the end probably that has the practice advisor, the practice support email. If not, we can maybe post that in the chat. So anybody who doesn't have a question answered, you can always reach out to your to the practice advisors at that email, and your profession-specific practice advisor will respond.
We have a question. Can you please speak to what, quote, designing a therapeutic diet includes for dietitians? For example, are OTs/SLPs able to design dysphagia management texture-specific diets? Are dietitians able to design based on texture?
Okay, I heard a lot of things on that question. So first I started thinking about the first portion, so I might need you to repeat the end again, which was specifically around what the dietitian can do. What was that portion of the question?
Are dietitians able to design based on texture?
Okay. Okay, so the new restricted activity in the regulation speaks to designing oral diet, which refers to therapeutic diet, which has a specific definition in the regulation. It refers to, I'm going to find it to make sure. So it refers to a diet that includes drugs, substance, or both. And it also refers to a diet that is designed for the purpose of preventing, managing, or treating disease, disorder, and condition. So we have received quite a few questions on this. We've had, I think, a meeting last week about this internally to discuss. I think the general message that I would send is that fluid and when food is being modified with texture and fluid consistency for the purpose of someone having swallowing disorder, it is a component of a therapeutic diet, but it is not all of what would constitute a therapeutic diet, because the therapeutic diet needs to, as I said, covers drug, if applicable, but also other substances, because there might be other conditions that the patient is having that is needed to modify food in order to treat, prevent, and manage a disease. So dysphagia is an interprofessional collaboration where the role of OT, SLP, and dietitian might vary depending where you are in the province, depending on which type of facility you are, depending on the strength and knowledge and additional education that each of these professionals might have been done. And the college recognized that everyone can have a role in contributing to patient safety on this. So OT and SLP can continue making recommendation on fluid and texture modification. It's important that they recognize that it's not what constitutes overall a therapeutic diet, and that they must work in collaboration with a physician or a dietitian to ensure that a complete therapeutic diet is being ordered for the patient, because there might be much more that is needed for a safe and rounded therapeutic diet to be delivered for the patient. But we do definitely, again, this new restricted activity was not meant to necessarily disrupt or stop some healthcare professional from contributing to dysphagia management and contributing to patient safety, but rather making sure everyone actually works together to provide safe care.
Thank you, Joanie. We have a question, wondering if you could speak to the importance of the collaborative care standard and how its application to all professions within the college enhances overall care delivery.
I can speak a little, and then Susan, I might ask you to speak more specifically to the standard. I think what I would like to comment on is that under the guiding principle of the Health Profession and Occupation Act, there is a very clear expectation that the college must promote and put measure to encourage interprofessional collaboration and even remove barriers. So there is an expectation that the standards and the work that we do actually encourage people to work together as opposed to doing their own thing. So when we drafted standard and when we think about how we issue responses, we are definitely aware of that. I think it's a great benefit of being a multi-profession college is that practice advisor speaks to each other all the time about what might be area where professional collaboration is important for patient safe care, which I think prior to amalgamation, like it was just a physical barrier that was there being separate entities. And we do see that it's a lot easier for us to be talking about how these different professions might intersect and work together and how the practice standard that we are drafting should help with that, not actually be a barrier. So, Susan, I don't want to, you were more involved in the drafting of the standard, so.
Yeah, just to say that was one of the positives we heard in during all the consultation periods around the standards was as particularly from the health authorities, there was support for that for the harmonization because they said it does make things difficult when we have people working together on a collaborative team and then their standards require different things of them. So I think that is, as Joanie says, one of the opportunities here.
Just as I look up a question, the whole screen moves. I'll go to one of the previous questions. How do the new regulations change any aspects of my daily practice and charting as a private practice PT? And there were a few questions about charting. So I wonder if, I don't know, Susan, if you could speak to that.
Sure. Again, they're harmonized standards, so they should look, the requirements should largely be the same as your legacy standards. As I say, they are likely less prescriptive. So where we might have had in a legacy standard a much more itemized list of the prescriptive details of what needs to be included, the standard might speak to it at a slightly higher level. So it says things like you're required to keep a complete and accurate chart versus having a long list of all of the details that need to be included. Mind you, there are quite a lot of lists or quite a lot of details that the record standard does specify need to be required. But I would say overall, aside from the fact that your record retention period, if you're a dietitian, has changed. If you're an OT or PT, you already had a 16-year retention period or 16 years. If it's a minor, you have to wait till the age of majority and then 16 years from there. But the biggest change in the record standard will be around record retention, how many years you hold it. And some of the legacy colleges had a requirement in their record standard to co-sign student entries. And that's no longer a requirement of the standards. It's still an option available. Some people will like to do that as a, part of their supervision process. And that's totally fine, but it's no longer a requirement. So I think those are the two big differences in the records retention standard.
Thank you.
The record standard.
And just looking at the clock, we're coming up on 1 p.m. and we want to respect everyone's time. Any last words from our presenters?
Yeah, well, first, thanks a lot to everyone attending. At first, I was like, oh, it's slow on the question. Maybe we'll finish earlier. And then I saw that all of you started to engage a lot. So thank you very much.
Yeah.
I still see there's quite a few questions in the chat. Some of them are very detailed and specific to your practice, which would really probably be best answered anyway if you send us an email. So I would encourage you guys, if we didn't get to your specific question, you can reach out to us and we will keep probably a copy of these questions too and think how best we can address these if they're high level, and that's something we can address in a future newsletter or a Q&A. As I said, we have more webinar, which will be hosted, I think tomorrow and next week for other profession. All licensees are welcome to attend, but each of them are a bit more tailored, as you saw today, for the profession that we're covering. So Thank you. Thank you so much for your time, would be my last word. And we hope to continue to provide more information that is useful for your practice as we move forward, and maybe more of these type of webinar. So thank you.
And don't forget just to note that practice support email on the bottom of the slide, practicesupport@chcpbc.org. So if your question didn't get answered, please do send it via email and your practice advisor will respond. Thanks everybody for joining.